Assalamu alaikum, this is Shama and today we are going to discuss a very important topic, that is rectal carcinoma. So, before we start the discussion, it's an humble request for everyone who is watching my videos. Please just take us 2 or 3 seconds and click on the subscribe button down the video. That will really help me a lot. It supports me and give me more motivation to make more good videos for all of you. Okay, so thank you so much. Coming back to our topic, we are going to discuss rectal carcinoma. Okay, so basically we will focus in this video over its management, that a patient came to us, how we will manage the patient of rectal carcinoma. So first of all, we will do some investigations in that patient. Now I'll explain you the investigations in very easy way. First of all, cancer is in the rectum. Cancer is always in the form of mass, so we can easily palpate it. Okay, so from this, first investigation will be per rectal examination, that is by manual with your fingers. Okay, now the most easiest way to remember its investigation is that, okay, this is the rectum, this is sigmoid colon, this is the descending colon, transverse, and moving on to the ascending colon. So just starting from here, rectum. Now we'll do the scopies. So proctoscopy, sigmoid colon, we call it sigmoidoscopy. Of colon is colonoscopy. Okay, so all these scopies are done to visualize these areas, plus biopsy to see the tumor. Of course, biopsy is standard test for identifying the tumor. And lastly is to find out the extent. Now this we have know that, okay, where is the tumor present by these investigations. To find out the extent, we go to do CT scan, but first of all, before CT scan, we do transrectal ultrasound, and in that we'll see that what is the extent of the tumor. Then we'll go for CT scan. Now CT of what? CT of chest, CT of abdomen, and CT of pelvis. Now you're wondering that why we are doing CTs of all these three areas. Very important. The rectal carcinoma, it metastasizes through blood and through the lymph nodes, but particularly, okay, I'll just explain you here too. Its metastasis is through blood, through lymph nodes, and locally. Okay, now locally it will extend longitudinally and transversely, leading to obstruction of the lumen. Okay, by lymph nodes. Now very easy to remember. We know it's colorectal cancer, so the lymph nodes are pericolic, perirectal, and mesentery of both of them. So mesenteric lymph nodes, it's spread by these three nodes. And by blood, remember the easy thing, LLB, liver, lungs, and brain, and bones too, but more important brain. So these are the sites of metastasis in case of rectal carcinoma, more precisely colorectal carcinoma, but we'll focusing on rectal carcinoma in this video. So yeah, these are the whole investigation setup that we have set for the patient. Moving on, that how we will manage, treat the patient. Okay, now of course we already know that basic management of the tumor is mostly surgery. So here is of course the surgery. Now very important point, I'll make it very easy for you. Imagine this is the whole rectum. Okay, upper 2/3 and lower 1/3. If the tumor is in upper 2/3, then the treatment surgery is anterior resection. Okay, why? Because it will be above here. But if the tumor is in lower 1/3 of the rectum, then we go for abdominoperineal resection. So these are the two major important procedures. Now I have made a very good way to easily recall and memorize these procedures and to easily understand them very easily. So let's just start our discussion over it. First is the anterior resection. Now just follow me. Okay, anterior resection. First of all, whenever we do a surgery, okay, now just imagine, open your mind. Whenever we do a surgery, first of all, we have to give an incision. Okay, then our step is that we will maintain the homeostasis of the respective area so that bleeding don't occur, because we have to cut that area. Then we have to remove all the protective coverings, or you can say the supporting structures of that organ that are removed to freely mobilize that organ. Okay, then we will remove the tumor plus its free margins, and then now after the tumor is removed, we will join the remaining structures so that the whole path is formed for the defecation, particularly in this case. Okay, now remembering these 3 points, first of all, incision. What we'll do is that lower midline incision is given in this case. Okay, after this incision, what we'll do is that we'll explore the inner structures, we'll find any metastasis present anywhere or tumor is localized and all that. Okay, second step will be we will restore homeostasis. How? Sorry. Inferior mesenteric vessels, these are ligated, so okay, we have restored the homeostasis. Third step is that now we will go for all removing the supporting structures and covering. So in that case, first of all, peritoneum will come. So peritoneal reflections, they are resected. Then the own mesentery, as we know that all the intestinal structures has their own mesentery, so in that case, mesentery of the rectum, that is mesorectum. So mesorectum is then cut. Okay, after this, now the rectum is fully mobilized, available for us to do. Now why we have cut mesorectum, and there is a procedure to cut mesorectum too. Coming back to this rectum, in the upper 1/3, mesorectum is present just posteriorly. In middle 1/3, posterior and laterally. And in lower 1/3, it is present in all the sides. So, depending on the site, we'll go for mesorectum excision. Like in the lower, total mesorectum will be excised. In the upper 2/3, wide part of it will be excised, that is up to 4 centimeter margins, that will be excised. Okay. So, now the rectum is fully mobilized. Now now what we'll do is that we'll cut the rectum. How? We'll place a clamp first. Now this is the rectum, rectal tumor, suppose here, and 2 centimeter free margins we have to cut now. So here we'll place a clamp 2 centimeter from the tumor localized. Okay, then we will resect this rectum part. Now this rectum tumor, it will then be resected. We cut this out, and so this is the resection step. And in the last step, what is that, since this part is now cut, now we will join the upper and the lower part. Means there will be an anastomosis formed between this descending colon and the lower 1/3 of the rectum. Anastomosis is formed, so the defecation process is continued. So this is the whole very easy procedure, how you can easily memorize that what is the procedure of anterior resection for upper 2/3 of the rectum, rectal tumors. Okay, now moving on to the lower 2/3 of the tumors, sorry, lower 1/3, I've told you before. For that, the procedure is abdominoperineal resection. Now from this name, you know that 2 parts are involved, abdomen and perineal. So just remember by it that 2 surgeons will do this surgery simultaneously. Interesting now? Yes. So one surgeon that will do it by this abdominal approach, what we'll do is that he will mobilize the rectum, as we have discussed in the whole previous procedure in anterior resection. Okay, the second surgeon that is doing it through the perineal approach, now what he will do is that he will give an incision, of course. Now where will that incision be located? From the tip of coccyx to the center of the perineum. Now this incision is made, and this incision is even continuous, that it will incise the anal sphincter. Now wound is created here. From this wound, we will remove the rectum and the anal sphincter from it. Okay, and we will stitch this wound back. Rectum and the anal sphincter is now removed, and we'll stitch this wound back. Okay, we will stitch this wound back, and the last step what we'll do is that we will join the above 2 parts. Okay, now the above 2 parts are Yeah, sorry, not joining the above two parts. What we'll do is that the colon that is left above, now we have to create a path of defecation in that patient too. So what we'll do is that colon is then joined with a stoma formed on the skin. That is, we'll do the colostomy in that case. So this is the whole procedure in abdominoperineal approach, and we have another option. Now there are some tumors which cannot be treated, like which are not operatable. So in that case, what we'll do is that we will try to reduce the size of the tumor first and then perform surgery. So in that case, we'll give chemotherapy and radiotherapy preoperatively to the patient to reduce the size of the tumor. Now, what are the options for chemotherapy? We have 5-fluorouracil plus folic acid is given to the patient, or the latest now are oxaliplatin or inotectin. Okay, so yeah, this is the whole before preoperative management, and then of course we will, when the size is reduced, then we can perform surgery again. So this is the whole management in case of inoperable tumors. And last is when the tumor is in advanced stage. Now what we will do, we all know that whenever the tumor is in advanced stage, we always prefer palliative therapy, that is the symptomatic therapy. Okay, now what we'll do in palliative therapy, first of all, to relieve the obstruction that the tumor is causing, we will make colostomy. Since rectum is causing obstruction, so we will make another path to avoid rectum to be used, because we can't perform surgery in those patients. So we will make colon attached with the stoma, colostomy is formed. And the last other, we'll go for chemo radiotherapy to reduce the size of the tumor. So this is all for management of rectal carcinoma. I hope you liked the video. I hope it helped you out and summarize the whole story of surgery for rectal cancer in your mind. If you like the video, please give it a big thumbs up, and thank you so much for watching, for your support. At the end, please subscribe if you've not done in the start. So okay, thank you so much. Allah Hafiz. See you in the next video.